Millions of people around the world live with mental illnesses. Thankfully, advancements in medicine have led to the development of medications that can help manage these illnesses. Among these medications, antipsychotics has become a fundamental class of medications in psychiatric treatment. Antipsychotics have transformed the management of conditions like schizophrenia, bipolar disorder, and depression, allowing many patients to lead functional lives. Antipsychotics, also known as neuroleptics, are a class of psychotropic medications categorized into two main groups based on their pharmacological profiles and side effect risks. Typical antipsychotics, also known as first-generation antipsychotics, emerged first in the 1950s, revolutionizing the treatment of psychosis. These medications share a common mechanism of action, primarily targeting dopamine D2 receptors in the mesolimbic pathway of the brain. By blocking D2 receptors, typical antipsychotics effectively reduce the excessive dopamine activity in this pathway, leading to a reduction in hallucinations, delusions, and disorganized thinking. Typical antipsychotics are strong dopamine D2 receptor antagonists, leading to effective psychosis treatment but high risk of extrapyramidal symptoms or EPS. Typical antipsychotics are grouped into several chemical classes including phenothiazines, thioxanthines, deuterophenones, and dibenzoxazepines. First-generation antipsychotics are further classified as high-potency, such as haloperidol and fluphenazine, which have increased EPS risk, and low-potency like chlorpromazine, and thioridazine, which cause increased sedation and anticholinergic effects. Their primary indications are schizophrenia, especially positive symptoms like delusions and hallucinations, acute agitation, and severe psychosis or mania. Atypical antipsychotics, often referred to as second-generation antipsychotics, emerged as a valuable alternative to typical antipsychotics. Unlike their predecessors, atypical antipsychotics exhibit a lower affinity for dopamine D2 receptors and a higher affinity for other neurotransmitter receptors, particularly serotonin 2A receptors. This unique pharmacological profile contributes to their therapeutic benefits and reduced risk of certain side effects. By blocking serotonin 2A receptors, atypical antipsychotics modulate serotonin activity in the brain, which is thought to contribute to their efficacy in managing both positive and negative symptoms of psychosis. Negative symptoms, such as apathy, social withdrawal, and lack of motivation, are often resistant to treatment with typical antipsychotics. The broader receptor profile of atypical antipsychotics may also play a role in their lower risk of extrapyramidal side effects compared to typical antipsychotics. Examples of second-generation antipsychotics are olanzapine and clozapine, which have high metabolic risk, risperidone and paliperidone with moderate metabolic risk, and aripiprazole and ziprasidone with low metabolic risk. Primary indications for atypical antipsychotics include schizophrenia, for positive and negative symptoms, bipolar disorder, treatment-resistant depression, and autism-related irritability. The mechanism of action of antipsychotic medications is complex and not fully understood. The dopamine hypothesis suggests that hyperactivity of dopamine transmission in the mesolimbic pathway is responsible for the positive symptoms of schizophrenia, such as hallucinations and delusions. Conversely, dopamine hypoactivity in the mesocortical pathway is associated with negative symptoms such as anhedonia and apathy and cognitive dysfunction. Antipsychotics exert their therapeutic effects primarily by modulating dopamine and serotonin neurotransmission in the brain, particularly within the mesolimbic, mesocortical, nigrostriatal, and tuberoinfundibular pathways. The differences in receptor activity between first-generation antipsychotics and second-generation antipsychotics contribute to their efficacy and side effect profiles. First-generation antipsychotics reduce positive symptoms of schizophrenia by blocking excessive dopamine activity in the mesolimbic pathway. High dopamine blockade in the nigrostriatal pathway leads to EPS such as drug-induced Parkinsonism, dystonia, and tardive dyskinesia. Dopamine blockade in the tuberoinfundibular pathway increases prolactin levels, causing hyperprolactinemia, gynecomastia, and menstrual irregularities. Second-generation antipsychotics have dual antagonism of D2 receptors and serotonin 2A receptors. Serotonin dopamine modulation leads to a more balanced neurotransmission, improving both positive and negative symptoms by reducing dopamine overactivity in the mesolimbic pathway while enhancing dopamine release in the mesocortical pathway. There's lower risk of EPS compared to typical antipsychotics due to the serotonin 2A antagonism increasing dopamine release in the nigrostriatal pathway. However, there is increased risk of metabolic side effects such as weight gain, diabetes, and dyslipidemia due to effects on histamine 1 and serotonin 2C receptors. Some atypical antipsychotics such as aripiprazole, brexpiprazole, and cariprazine act as partial dopamine agonists rather than full antagonists. They stabilize dopamine activity, reducing excess dopamine in the mesolimbic pathway while increasing dopamine where it is deficient. They have lower risk of EPS and prolactin elevation, and lower risk of sedation and weight gain compared to other SGAs. Atypical antipsychotics target serotonin 2A receptors, affecting dopamine pathways. This modulation may improve cognitive function and reduce negative symptoms. Lumateperone is a selective D2 receptor modulator, acting as a presynaptic D2 receptor partial agonist and a postsynaptic D2 antagonist. It also has strong serotonin 2A antagonism, which enhances dopamine release in mesocortical pathway to improve negative symptoms. Additionally, it also has glutamatergic modulation via NMDA receptor enhancement, which improves cognitive function. A combination of olanzapine and samidorphan provides the strong antipsychotic efficacy of olanzapine as a D2 and serotonin 2A antagonist plus samidorphan, a M-opioid receptor antagonist which mitigates olanzapine-induced weight gain. The clinical benefit of the drug is that it helps address long-term metabolic concerns associated with olanzapine. A recently FDA-approved medication for schizophrenia operates through a novel mechanism. Unlike traditional antipsychotics that block dopamine receptors, it has two components, xanomeline and trospium, which exert their action on different receptors. Xanomeline acts as an agonist at M1 and M4 muscarinic receptors, indirectly influencing dopamine and glutamate pathways in the brain. Trospium, on the other hand, counteracts potential peripheral muscarinic side effects without crossing the blood-brain barrier. This innovative approach offers a promising alternative for managing schizophrenia symptoms while minimizing common side effects associated with older treatments. Antipsychotic medications have unique receptor binding profile, influencing their therapeutic effects and side effect profiles. Asenapine acts as an antagonist at multiple receptors, including serotonin, 2A, 2C, D2, D3, histamine 1, and adrenergic receptors. It has no significant affinity for muscarinic receptors, which helps reduce anticholinergic side effects. Allopuridone works by antagonizing D2 and serotonin 2A receptors. It also has activity at alpha-adrenergic receptors, which can contribute to side effects like orthostatic hypotension. Lurasidone is another atypical antipsychotic that blocks D2 and serotonin 2A receptors. It also has high affinity for serotonin 7 receptors and acts as a partial agonist at serotonin 1A receptors. Unlike some other antipsychotics, it has minimal activity at histamine and muscarinic receptors, which reduces sedation and anticholinergic effects. Risperidone primarily acts as an antagonist at D2 and serotonin 2A receptors. It also has activity at alpha-adrenergic and H1 receptors. Quetiapine blocks D2 and serotonin 2A receptors. It also has effects on histamine 1 and adrenergic receptors, which can explain its sedative and hypotensive effects. Aripiprazole is a partial agonist at D2 and serotonin 1A receptors, while also acting as an antagonist at serotonin 2A receptors. This dual action helps stabilize dopamine activity, earning it the label of a dopamine system stabilizer. Brexpiprazole acts as a partial agonist at D2 and serotonin 1A receptors and an antagonist at serotonin 2A receptors. It is classified as a serotonin dopamine activity modulator. Ziprasidone antagonizes D2 and serotonin 2A receptors. It also has moderate serotonin and norepinephrine reuptake inhibition properties, which may contribute to its antidepressant effects. Olanzapine blocks dopamine D2 and serotonin 2A receptors, along with activity at histamine 1, muscarinic, and adrenergic receptors. This broad receptor profile contributes to its efficacy and side effects. Cariprazine acts as a partial agonist at dopamine D3 and D2 receptors, with a preference for D3 receptors. It also has partial agonist activity at serotonin 1A receptors and acts as an antagonist at serotonin 2A receptors. Clozapine works by antagonizing dopamine D2 receptors and serotonin 2A receptors. It also has activity at other receptors including H1, muscarinic, and adrenergic receptors. This broad receptor activity contributes to its effectiveness in treatment-resistant schizophrenia. The use of antipsychotics requires careful consideration of individual patient characteristics, including age, medical history, and potential drug interactions. Specific populations, such as children, adolescents, pregnant women, and older adults, may have unique needs and vulnerabilities that necessitate adjustments in treatment approaches. In children and adolescents, antipsychotics are typically reserved for severe cases of psychosis, such as childhood-onset schizophrenia or bipolar disorder with psychotic features. Regular monitoring of growth, development, and metabolic parameters is essential. Obtaining informed consent for antipsychotic medication in pediatric populations presents unique challenges and ethical considerations. Children and adolescents, by virtue of their developmental stage, may have varying capacities to understand complex medical information and make informed decisions about their health care. Involving both the child or adolescent and their parents or legal guardians in the informed consent process is important. The healthcare provider should explain the proposed treatment plan in age-appropriate language, addressing the child's concerns and questions directly. Parents or guardians should also have ample opportunity to ask questions, express concerns, and participate in decision-making. The goal is to create a collaborative environment where the child's voice is heard and their best interests are prioritized. Obtaining informed consent involves respecting autonomy and understanding risks. Adults have the right to make their own healthcare decisions. Providers must offer comprehensive information and support. For severe mental illness, assess decision-making capacity. Use a substitute decision-maker if necessary. While antipsychotic medications offer significant benefits in managing the symptoms of various mental disorders, it's essential to acknowledge and address their potential side effects. Children have higher sensitivity to weight gain, sedation, and behavioral disinhibition. Use only when necessary with regular metabolic monitoring. For adults, consider past treatment response and comorbidities. Monitor for metabolic and cardiovascular risks. For the elderly, there is higher risk of sedation, falls, and stroke. Lowest effective dose should be used with careful monitoring. Drug-induced movement disorders, formerly called extrapyramidal side effects, or EPS, are a significant concern with typical antipsychotics. These side effects result from blocking dopamine D2 receptors in the nigrostriatal pathway. Acute dystonia presents with muscle spasms, oculogeric crisis. Management include IM benztropine or diphenhydramine. Parkinsonism includes tremors, rigidity, slow movements, and postural instability. There may be shuffling gait, mask-like facial expression, and reduced arm swing. Management include reducing dose, switching to SGA, or adding amantadine. Akathisia is described as inner restlessness and pacing. Management include propranolol or benzodiazepines. Tardive dyskinesia, or TD, presents as involuntary facial or limb movements. Management include VMAT2 inhibitors such as valbenazine or deutetrabenazine. Atypical antipsychotics, while generally having a lower risk of extrapyramidal side effects, are associated with a different set of potential adverse effects, primarily metabolic disturbances. These metabolic side effects including weight gain, dyslipidemia, and an increased risk of type 2 diabetes. Therefore, proactive monitoring and mitigation strategies are crucial for individuals receiving atypical antipsychotics. Weight gain is a common concern with atypical antipsychotics. Consider medication adjustments if significant weight gain occurs. Tardive dyskinesia is a movement disorder with involuntary repetitive movements, often affecting the face, mouth, tongue, and extremities. These movements can be physically and socially debilitating, impacting quality of life and self-esteem. They often manifest as grimacing, lip smacking, tongue protrusions, or rapid blinking. Movements may involve the trunk, limbs, or fingers, leading to rocking, swaying, or jerking. These movements can interfere with daily activities like speaking, eating, and writing. Managing tardive dyskinesia presents a significant challenge due to the lack of a definitive cure and the potential for irreversible movement disorders. Treatment approaches primarily focus on mitigating symptoms and improving quality of life in a structured approach. Step 1. Discontinue or adjust offending agent by reducing dose or switching to a lower-risk SGA, such as quetiapine or clozapine. Step 2. Administer FDA-approved treatment, VMAT2, inhibitors such as valbenazine and deutetrabenazine, which are first-line therapy. Step 3. Consider adjunctive therapies such as clonazepam for symptom relief or ginkgo biloba, which has some evidence of mild benefit. Step 4. Prevention. Routine aims or abnormal involuntary movement scale every 6 months for long-term antipsychotic users, and avoiding unnecessary long-term antipsychotic use when possible. AIMS testing may have to be done more frequently if patient is at high risk for developing TD. Antipsychotic medications offer hope and improved quality of life for individuals with schizophrenia and other mental disorders. To ensure safe and effective antipsychotic use, the following monitoring plan should be implemented. AIMS testing every 6 months, if not more frequently. Monitor weight and BMI monthly for first 3 months, then quarterly. Check lipid panel and glucose at baseline, then annually. ECG, QTC monitoring at baseline and as needed in high-risk patients. By balancing efficacy, safety, and patient-centered care, we can optimize antipsychotic use while minimizing risks.